Welcome, everyone. We'll just give it a minute for folks to join. Okay, my clock says 3 p.m. Eastern. I think we'll get started so we can make the most of our time together. Thank you, everyone, so much for joining today's webinar on information we want to share with you all about addressing equity in home and community-based service for Medicare and Medicaid beneficiaries. We appreciate you taking the time out in your busy schedule to join us today. So before we jump into the content for today, we'll go to the next slide, please. Just want to run through a few housekeeping details. If you have any questions, please use the Q&A feature on our webinar, and we will save ample time at the end for discussion. If you need closed captioning, it is available using the caption button at the bottom of your Zoom screen. And we are recording this webinar, and we will share the recording along with all the materials that we reference afterwards to those who signed up. Next slide, please. So just a little bit about 3 organizations that collaborated on this project. Each of these organizations brought a unique skill set in examining our research questions. So Community Catalyst, the organization that I work for, we are a national health advocacy organization dedicated to building the power of people to create a health system rooted in race equity and health justice, and a society where health is a right for all. The Leading Age LTSS Center at UMass Boston, they conduct research opportunities associated with a growing older population. And the Institute for Community Health is a nonprofit consulting organization specializing in participatory program evaluation, applied research, assessment and planning, training and technical assistance to help local communities and organizations create sustainable health. Next slide, please. So as you'll see on your Zoom screen, the 3 of us will be your presenters for today. We have myself, Carolyn Fisher, who is a research and evaluation scientist at the Institute for Community Health. My colleague, Mike Brand, also works with me at the Center for Community Engagement and Health Innovation at Community Catalyst. Our next slide, please. For our agenda today, we would like to review our research objectives and methodology with you. We will share with you some of our key findings from the literature review, our quantitative and qualitative analysis that we conducted, and then share with you some of our policy and practice implications that we've recommended in our report. So we will move to the next slide. Thank you. And not surprising to many, currently over a third of individuals who are duly eligible for Medicare and Medicaid rely on home and community-based services to remain in their communities and avoid moving into institutional settings like nursing homes to address any functional or cognitive needs. And there's a lot of research out there suggesting the fragmentation between Medicare and Medicaid system creates real challenges for this population in accessing not only the traditional acute services, but also services like long-term care. The pandemic, the COVID-19 pandemic, only made these challenges worse as states struggled to allocate resources to the system, and it resulted in high mortality rates in nursing homes. The pandemic also shed light more significantly on the racial and ethnic disparities in access to care, leaving individuals of color extremely vulnerable. Our project really quantified racial and ethnic disparities in access to home and community-based services and shed light on some of the potential policy levers in addressing these disparities. What we ultimately hope is this work will enable policymakers to develop better informed policies that can address racial and ethnic disparities in a set of services that are critical for helping people age in place. The research questions that we explored were As you see on the slide, what disparities in access to and quality of home and community-based services exist for dually eligible beneficiaries of color, and how do we mitigate those disparities through policy and practice changes? Next slide, please. So some of the key ways we went about doing this is conducting an environmental scan. We looked at scientific and gray literature to capture the national landscape of disparities in access and how that changed over time. The LTSS Center conducted the quantitative analysis, utilizing the longitudinal database to understand changes in access to care, factors that influence how and why individuals begin using care, and disparities based on a range of characteristics. And qualitative research, we conducted stakeholder interviews and focus groups to better understand their perspectives in terms of access to home and community-based services. So in our next slide, as I said, we reviewed recent academic and gray literature to identify the nature and extent of racial and ethnic disparities in access to these services. While the review focused largely on articles studying populations that are dually eligible, we also expanded our view to include some closely related populations, those who are eligible just for Medicaid or just for Medicare, so that we can have a more expansive body of literature to review. And the literature was definitive in highlighting the presence of racial and ethnic disparities in access. People of color are more likely to have long-term service and support needs and receive no help from informal care or home and community service. There's more limited access to a wide variety of home and community-based services. They experience poor health outcomes, which are postulated to be related not having their needs met through family or home and community-based services, and lower utilization and expenditures overall with regard to certain specific services, which we'll get into a little bit more. In the next slide, please. Some of the key drivers that we identified in the literature review that contribute to disparities are the inequities in supply of resources in communities of color, limited access to managed care, individual bias and systemic racism likely played a role in creating inequities. And other factors that played a role is the underlying comorbidities. So where greater health burden or complexity could worsen outcomes or compromise access to the proper package of specific home and community-based service supports. And additionally, having limited caregiver supports or caregivers with more limited access to information and training can also confound issues of access to care. Some other community variables also played a role. Lack of transportation, limited internet for telehealth, for obtaining information about providers, limited provider supply, and other community factors that can affect communities of color differently. We'll move to the next slide, please. So what we learned from our stakeholder interviews, we asked them to put forward their thoughts on policy changes that could lead to a reduction in disparities in access and utilization of home and community-based services for this population. Stakeholders included executives and key leaders in this space, provider organizations, researchers, federal officials, and advocates. The results of these interviews we aggregated and analyzed to draw the common themes that are displayed right now. And a few of them being discrimination, concerns about immigration status, and a lack of language accessibility are barriers to using these services. Some of the other structural barriers include long waiting list, fragmented delivery system, and limited transportation to service locations. And the historical legacy of racism, including redlining and segregation, has led to fewer resources being available in communities where there's a disproportionate share of older people of color. Next slide, please. So the LTSS Center conducted the quantitative analysis, and they used data from 2010 to 2018 wave of the Health and Retirement Study, which is a nationally representative longitudinal survey of individuals who are age 50 and over. We identified whether and in what magnitude these disparities exist for dually eligible individuals of color, whether patterns changed over time, if there were differences between region, urban, or rural setting status, and whether individuals of color have similar or different experiences compared to white beneficiaries. And a big factor, as noted here, is having a usual source of care is important in reducing racial and ethnic disparities in home and community-based services utilization and reducing unmet long-term service and support needs. The prevalence of utilization across the dually eligible population declined between 2010 and 2018, and the reported level of unmet need increased. You'll note here, dually eligible individuals who are in managed care plans significantly were more likely to have a usual source of care than those in fee-for-service plans. So enrollment in managed care could potentially help in maintaining a usual source of care. I would really note here, while encouraging participation into managed care plans could be useful, this has to be done with caution, as concerns have been raised around managed care arrangements. I think, in any design and implementation of managed care policies has to be attuned to what the community needs, what this population needs, what advocates and family caregivers are saying and their feedback and desires around managed care. So I will stop there. We'll move to the next slide, and Carrie will be taking over from here, sharing focus group findings. Carrie?
Thanks, Lena. So our next step was to conduct focus groups with dually eligible people to learn the ways in which the patterns that we'd seen in the previous components of the study were playing out in people's everyday lives and to understand some of the reasons for those patterns. So we conducted virtual focus group sessions with people in 5 states: Alabama, Arizona, Tennessee, Michigan, and Pennsylvania. Eligibility criteria were that people had to be 50 years of age or above. They had to be both enrolled in Medicare and Medicaid, identify as Black or African American, Hispanic or Latinx or Native American, and they had to be adults with activities of daily life limitation and with long-term service and support needs. Next slide, please. After conducting the focus groups and doing the data analysis, we also did a feedback forum with the people who had previously participated in the focus groups. So all 52 participants were invited and 17 people attended. And the purpose of this was to member check the findings. Through this process, we were able to deepen our findings and understand which themes that had arisen during the course of our data analysis were most resonant with the people that we had talked to. So we did a facilitation style based on World Cafe, in which there were 3 breakout rooms, and there were 3 facilitators. Each of us took one category of findings, and we rotated between rooms. We took notes on the participants' reactions on Jamboards, and each breakout room was able to react to the previous room's Jamboards. And this was a way that we made our findings richer and deeper. Next slide, please. So what we found in these focus groups were, first of all, we wanted to understand how people choose providers. That was one of the questions that we went into this data collection holding. However, the folks that we talked to did not usually feel like they were making a choice between different providers. Instead, provider choice was generally based on practical considerations. That is, the ability to find any willing or appropriate provider to fill people's needs. So that was the primary way that people chose their providers. There were also program eligibility requirements and personal recommendations that played into the way that people were navigating the system and selecting providers. Next slide, please. And we found that both family and professionally provided care have important roles to play in meeting the home and community-based service needs of individuals. There were very few people who were only using paid care. In most cases, the folks who did have paid care were also using family care to fully meet their needs. In some cases, there were gaps in care, and family members were filling those gaps. Family members were also managing the paid caregivers, helping them understand what the needs were and how to fill them. Um, in some cases, the family caregivers were seen as the primary source of care, and when paid caregivers were able to come in, that was understood as respite for the family caregivers. And finally, we found that relationships with family caregivers and relationships with paid caregivers can be complex. Next slide, please. Participants really didn't agree about whether they preferred family caregivers or paid caregivers. Some people felt strongly that paid caregivers were better. Some other people felt strongly that family caregivers were better. However, there was general consensus about what makes a good caregiver. And the themes that emerged around descriptions of a good caregiver are that they are trustworthy, and trust is super key and a very strong theme. They also needed to be reliable, and they needed to be caring. They needed to be able to build a relationship of care and affection with the person receiving care. Participants also prioritized good communication and people with whom they could build relationships of mutual respect. They wanted to be able to respect their caregiver, and they wanted to feel that their caregiver was respecting them. Next slide, please. We also asked first about participants' personal experiences with racism, and then about how they would interpret the quantitative findings that we found showing racial disparities in HCBS use. So, participants described both subtle and overt experiences of racist interactions with their HCBS caregivers and care managers. Various participants shared their perceptions that some providers are less willing to serve people of color, um, both both subtle and just coming right out and saying this. Participants were also very aware of the structural and historical racism that impacts them and impacts their families and their communities, and how it's negatively impacted them. Some participants made an association between historical racism and structural racism and feelings of vulnerability and mistrust, pointing out that even if current providers were wonderful, past experiences made them more likely to feel vulnerable and to be slower to trust caregivers due to these experiences. So those were the findings from the focus groups. I am now going to turn it over to Mike.
Thank you, Carrie. I will be discussing with you all the policy and practice implications we developed as a team, specifically how we arrived at our recommendations, our top policy priority areas, and some more targeted recommendations pertaining to the aspects of care you see listed on this slide here. As a team, we started by reviewing our findings, including our quantitative analysis, learnings from focus groups and key informants, and our literature review. And then we took the implications from these findings and broke them down into recommendations in these categories: access, quality of care delivery, cultural responsiveness, workforce and workforce quality, and data practices. From there, we looked at which of those recommendations are, one, highly relevant across all of our findings and various research processes, and two, based on our knowledge of the field, have the potential to move the needle forward across several of the aspects of care you see here, and would be most impactful in reducing disparities. Here you can see our policy priorities, policy priority areas. Connect beneficiaries with a usual source of care. Essentially promote ways to ensure people have an active relationship with a provider or healthcare location that they can go to as a first line of support for their health needs. And this is very much informed by the findings Lena shared and the LTSS Center did related to the HRS quantitative analysis, which shows a usual source of care as a key factor in reducing disparities and making sure people have less unmet HCBS needs. Strengthen the home and community-based workforce. Workforce shortages and issues facing direct care workers are well documented. And we heard time and time again that accessible and high quality care requires a robust and high quality workforce, and specifically a workforce that can provide culturally and linguistically appropriate care, which are essential factors in reducing disparities. And engage beneficiaries, families, and caregivers. Engagement builds trust between health systems and communities and providers and care recipients, something that's critically important to obtaining positive outcomes, especially when distrust exists. So meaningful engagement also ensures that community voices and experiences from discussions around experiences inform discussions around policy and practice. Within each of these priority policy areas, we also put forward actionable policy recommendations to help move towards a larger goal. For example, to connect beneficiaries with a usual source of care, states and health plans can provide incentives that encourage duly eligible beneficiaries to enroll in managed care programs. Incentives can be provided to both managed care and traditional Medicare to connect beneficiaries to a usual source of care. And programs such as PACE and Capable can be prioritized, which have been shown to improve both access and quality of care. However, as Lena mentioned earlier, while our findings show a benefit to managed care, a number of concerns have been raised regarding managed care arrangements. So it's important that any design and implementation of the policies above be attuned to health advocates' feedback and desires. Meaningful engagement and collaboration with advocacy and beneficiary organizations in the design and implementation of managed care programs and any incentives can help ensure that these policies do not create unintended harm. And all policies should ensure that beneficiary choice is maintained and people are provided access to a range of provider options. Accountability should also be built in through clear standards for managed care and performance measure requirements. Some examples of this include measurements or standards that incentivize usual source of care, improving primary care access, expanding telehealth and telemedicine, strengthening care coordination, or generally enhancing health insurance coverage. Some policy levers to strengthen the home and community-based workforce include states can require livable minimum wages for direct care workers, and CMS can support states in doing this through technical assistance and guidance. States and localities can build career pathways, fund targeted recruitment, and hire staff that are representative of the communities they support. Specifically, pathways to leadership and management positions should emphasize recruiting staff who share cultural backgrounds and or speak the primary language of the communities that the organization supports. It's at these positions where decisions about programmatic priorities and budgets are often made. And CMS and states can implement differential provider payment rates for providers who primarily serve duly eligible people of color. We also feel that meaningful engagement is a cornerstone of making sure systems are accountable to and meet the needs of the people they are designed to support, especially those historically left out. And we believe meaningful engagement should happen in all aspects of HCBS care, ranging from policy creation to service provision. Some examples of how this can be enacted include state and health plans and health systems can create beneficiary and family advisory committees. Health systems and providers can prioritize active engagement and care planning with beneficiaries and their caregivers. And providers can engage beneficiaries and family caregivers as managers and bosses of their care and care team. In addition to these broader initiatives, we also believe targeted policy interventions pertaining to access, quality, cultural responsiveness, workforce quality, and improved data practices will lead to reductions in disparities. These are some examples, and our report includes additional recommendations and details. We also want to recognize that there are some widely accepted and important issues that continue to need to be addressed, such as reducing the institutional bias in Medicaid and reducing waiting lists. And in addition to these, we believe we unearthed some unique and actionable recommendations in each of these areas. For example, related to access, policymakers can consider a system that prioritizes individuals with the greatest care needs are those who live in underserved communities. Given that needs are often greater among older adults of color, such criteria could then help to overcome some disparities in access. Related to quality, we feel it's essential to both obtain input from individuals who use home and community services about what measures matter most to them, and to add quality measures that address the needs of specific subpopulations. And something that came up in our research related to cultural responsiveness is that collective and individual trauma has a profound impact on people's needs and relational styles. So ensuring that engagement touch points are trauma informed could contribute to building trust among beneficiary populations. So for example, trauma informed outreach, enrollment, and services. Related to workforce quality, often care recipients are managing a complex system of providers, benefits, and scheduling. And support should include skill building and training to make sure beneficiaries and their families and caregivers have the necessary tools to complete these tasks and manage at times tough conversations about their needs or provider performance. Even as the direct care workforce is bolstered, self-directed care and family caregiving will remain an essential aspect of home and community-based systems. And finally, related to data practices, given the wide range of services that are provided under the umbrella of home and community-based services and their highly localized nature, it's challenging to obtain an overall picture of system performance. Developing a data and research clearinghouse for home and community-based research could help to diffuse local successes more quickly across the country. And as part of this effort, it is important to directly engage home and community-based service recipients in data development and research project development. And with that, I'm going to pass it back to Lena for a discussion and question session.
Thank you, Mike. So we're seeing lots of questions coming up in the Q&A. Thank you so much for putting those in there, and I think I saw some in the chat too. So we will do our best to navigate those, but feel free to ping us again if we miss your question. There were a few questions about how we recruited participants for the focus group. I put into the chat, but we recruited focus group participants by working with community organizations in the 5 states that we were in. We had relationships with local and state advocacy groups whom we worked with to provide background on the type of individuals we were looking to recruit and work together on screening questions, and then they supported us in recruitment efforts. Let's see, the next question I see was around someone asking to define historical versus structural racism. My team can jump in. Historical was emphasizing that it's been going on for a long time. Structural racism is built into the institutions and the systems we're in, which is also historical. I'll see if Carrie or Mike want to add anything else to that.
Now that works for me.
Yep, and there was a question in here, and maybe Mike or Carrie might be able to. How strong, if any, were the findings on increasing workforce through patient navigation workers, or did we see any mention of this in the focus groups? I know in the report we certainly have recommendations around workforce, and it came up in our focus groups. If you have more to add on that.
We did not talk to a large number of people who had had experiences with patient navigators. Those who did had positive experiences, but I don't think that the findings were strong enough to, uh, to emerge as a strong theme one way or the other. Certainly, people were looking for help in finding people, in finding HCBS workers. Um, but yeah, I don't think we had enough people who'd had that specific experience to speak to that.
Thanks, Carrie. Other questions, or go ahead, Mike. See, you came
Oh,
on.
I was just going to add that while we maybe didn't hear about it directly in this project, through other focus groups and other work we've done, we have heard of the importance and just the desire to have support navigating services, especially some of the difficult barriers that exist with enrollment.
There's a question, did the evaluation attempt to look at racial disparities in HCBS access usage spatially using GIS tools?
I'll say we did not attempt that, but that would be an incredibly cool study. I think it could potentially be really insightful. We know that geography contributes a lot to people's experiences, if for no other reason than for transportation reasons. And we suspect that neighborhoods and other spatial understandings would emerge in a thing like that. So let me know if you decide to do that study, because that sounds very cool.
A question coming in, maybe you can share a little bit about it just popped away. What was the age range of the participants in the focus group and the level of need? I know we have that information.
Give me a minute to look that up and I can get that.
There we go. I found roughly 70% of our focus group participants identified as Black African American, and most focus group participants, about 75%, were between the ages of 50 and 69 years of age. Okay, let's see another question coming in here. Can you share any thoughts about how different usual sources of care may be more or less connected or prepared to refer individuals to non-medical community-based support services that typically represent long-term services and supports? Oh, that's a good question. Any thoughts from my colleagues, or even folks on the call would welcome any thoughts. I think from this work and previous work, and Mike can also attest to this, how folks, and I'm going to make sure I'm getting your question correct, Catherine. People being referred to non-medical services or community service, one of the things we found as a theme is that is not happening in a uniform way. There is information barriers, and there was a lot of different reasons for that, whether it was health literacy, whether it was access, where the individual is living, urban setting or a rural setting. I know that came up. And there was one other piece, Mike, maybe you can help me on that one. The different things that came up in terms of information access.
Yeah, related to that question of how different usual sources of care may be helpful in connecting people, I think that's a great next step in this research. The usual source of care, as it was measured in the HRS, was one question about where people received or if they had a usual source of care. And so getting into the nitty-gritty of how each different type of usual source of care and what people's usual source of care is and how that impacts if they get connected, I think would be kind of a next step or something that would require further research, if that makes sense. But also we can confer with our research colleagues and get back to you on that.
Another question that came up were around disparities between states that had implemented Medicaid expansion and those had not for dually eligible individuals. That's a great question, and we did not look at between expansion states and non-expansion states. But that would be really interesting, actually.
I saw somebody specifically wanted to know how many people who are participating identified as Native American, and out of our 52 participants, 3 were identified as Native American.
Another question, it's a good point, Dennis. PCPs are often cited as coordinator solutions despite their lack of knowledge of home and community-based services or desire to serve people with HCBS needs. Why is this? Good question. I'd love if others had thoughts on this piece. I think we've come across this as well in other research that we've done. Other questions from participants? Or comments, suggestions? Or even reactions to the policy and policy implications that we shared? Look through our Q&A box again. Oh, I believe Dennis has his hand raised. Would we be able to unmute his line, Mike?
Yeah, let me just do that really quick.
Okay, I think you can go ahead, Dennis.
Thank you. So much of what you shared, let me break this down. There's a statement, then a comment, then a question. Was really helpful. I appreciated that people said trust. Was it the 3 pieces that it was what trust, reliability, and caring, or something? With those are 3, right? Yeah, and that resonates across, I think, all populations. And so that's something to really keep in mind as the system looks to medicalize HCBS and home and community-based services, is that they keep looking at professionalizing and medicalizing people going to the home, increased training, increased whatever it may be, as opposed to really looking at reliability, trust, relationship, caring. And so they've actually, by putting requirements in, maybe pushing people out that would really be great at this work. That's another comment. Is it's great to see a lot of the stuff that you found resonates across a lot of populations, but like drilling down to racism specifically, was there anything that you came away from this feeling like, wow, this could be impacted by XYZ policy, or was there anything that like that people felt strongly about, saying the care providers are racist, or the PCPs, or the system, or like what was it that you came away with that we can't see here, that's maybe in your paper?
I will sort of give my perspective on this and what I came away with, and Carrie and Mike can jump in. But I think some of the things which is in the paper, one was around care providers. To me, this research and other research that we've done has really shown, having a personal care provider comes into your home, who speaks your language, understands your culture, just it's really important. The trust that comes with that. The other piece I think that our paper identified, and I think additional research probably is happening, was really around trauma-informed care and culturally appropriate practices. And I feel like that needs additional discussion, and probably research, but that certainly came up, I know, in the focus groups, and in some of the literature that we reviewed. And those are kind of the things that really kind of stuck out for me.
Yeah, and I just want to say, Dennis, I think that your point about trust and that the sort of the adding the need for credentials can potentially like push people out of the profession. I think that's a really interesting and good point. And I'll just add that we did hear people saying that they wanted more credentialing of home and community-based service providers. And I believe that the root of that was one way to get to trust. I don't think that it's people don't necessarily want carers with high levels of credentials because for their own sake. I think it's because that's one way to build more trust with people. So if I had to point to one root cause, it would be the trust thing.
Yes, so we will be sharing the recording, the slides, the link to the report. We will share that with this group and more widely through different channels.
Nina, there's a few more that have shown up in the Q&A. Specific policy recommendations around how to reduce waiting lists. And then any research that we could suggest around clearinghouses.
Just hopping through. Yes, I think for the additional research, we can share, and once you see the report, we have a link to all of the literature, which you can see some of the information found around that. Sorry, the other question on waiting lists. Mike, can I ask you to address what we shared in our report about waiting lists?
Yeah, so I think looking at the question, it was sort of along the lines of waiting lists seem to be a funding issue, like there not being enough waiver slots or availability of services, and is there other ways to address them? I hope I'm interpreting or reading that question correctly. But besides additional funding or expanding, HCBS services, the ways that we discuss potentially improving waiting lists, because there's a dearth of information about waiting lists, like who's on them and what their needs are, is to sort of bolster that data and start prioritizing people based on their needs or coming from underserved communities, so that waiting lists, we know, can have sort of a disparate impact on someone. For one person, being on a waiting list can mean one thing, and for another person, depending if their needs are higher, it can have waiting a year or so can be much more challenging. So adjusting waiting lists to take those things into consideration can help better meet people's needs. And I hope that gets at what you're asking.
I'm seeing a question from Hannah Diamond asking whether we looked at the impact of intersectional identities and impact on access to care. And that it was not one of the questions that we asked in the qualitative things. However, we did hear that the type of disability that a person was experiencing very much impacted the ways in which they experienced their vulnerability regarding caregivers and the degree to which trust was seen as a challenge. So for example, people who needed transportation had one degree of need for trust. People with visual impairments who needed help, for example, with reading sensitive mail and even paying bills, felt additionally vulnerable. And certainly, I think intersectional identities and that impact is a super significant topic that definitely bears further exploration in future studies.
Yeah, and I'll just add to that while it came up in some of the focus groups and some of our key informant interviews, some of the limitations of the data in the HRS are that race and ethnicity are considered together. And some of our identifying information about, people's various identities couldn't be stratified or disaggregated to the level that would be really helpful. So again, I think this is also something that would be excellent to explore in future research and really dive into some of our findings.
Thank you both. Other thoughts or comments, or questions before we close? We really appreciate this discussion. I think there's a lot we did learn, and I think there's a lot more to learn in this space, to be thoughtful about how we move in the policy direction. Okay. So our next step is we will be sharing out the full report, these slides, and the recording to this group and to others through our networks. And feel free to share with others in your networks as well. Great. Thank you all for joining. I don't know if my colleagues have any final thoughts, but I think we can close.
Yeah, I would just say thank you all for joining, and thank you so much for these really great questions. We definitely want to save these, and I think it's really helpful input on what we're putting forward is in terms of policy recommendations and future directions.
Thank you so much. Take care.
Thanks, everyone.
Bye.